Hi, good afternoon. We're about to resume. Raise your hand if you're able to hear me clearly. All right, that's good enough. That is good enough. All right, so this afternoon we're gonna look a little deeper at the physiology of breathing, specifically the primary stimulus to breathe and the secondary stimulus to breathe. Right now, at this stage in the course, hold on, my background is a bit noisy. Hold on. Okay, I'm back. At this stage in the course, you would have learned that the primary stimulus to breathe, or the area of the body that controls breathing, is the brainstem. So the brainstem controls our ability to breathe. Now, within the brainstem, you have what is called the primary respiratory center, or primary stimulus to breathe. So there are chemoreceptors, chemical receptors within the brainstem. And these chemical receptors, or chemoreceptors, respond to changes in the pH of the cerebrospinal fluid. And we learned about pH. So basically what is happening, which when there is too much carbon dioxide in the body, that carbon dioxide will combine with water to form a weak acid, which is carbonic acid. If it continues to build up in the body, the pH will become more acidic, which is less than 7.35. The brainstem picks up the change in the pH. So the brainstem is picking up the change in the pH as a result of the increased CO2 in the body. And then a stimulus to breathe will be created. Right? So the breathing rate is going to increase to breathe off the CO2 to get it to a pH that the body can function effectively, which would be 7.35 to 7.45. So that's the primary stimulus to breathe. What are the take-home points from that? The primary stimulus to breathe comes from the brainstem. The brainstem doesn't actually pick up changes in gas. It picks up changes in the pH. So it picks up when the pH becomes too acidic or too alkaline, and it adjusts the breathing accordingly. But if the pH is too acidic, it is as a result of increased CO2 in the body. Right? So that's the primary stimulus to breathe. Go ahead, Mr. Graham.
Yes, sir. Is the pH measured in percentage, or there any unit of measure for that?
I just told you 7.35, no percentage
No
here.
percentage, no unit. All right.
All right, now where was I? Sorry about that. The hypoxic drive now. Now, if the central chemoreceptors, or the primary stimulus, is not working effectively, the hypoxic drive will take over the breathing. Now, With the hypoxic drive, what is happening is the brainstem is no longer regulating the stimulus because the brainstem is too sensitive, right? The brainstem is too sensitive. So the chemoreceptors for the hypoxic drive are located in the arch of the aorta and the carotid arteries. And what these receptors are responding to is a low concentration of oxygen. So it's stimulated by low oxygen levels. Now, a patient with a hypoxic drive stimulus is a patient that has chronic respiratory problems. So this is a patient that has COPD, chronic obstructive pulmonary disease, patient who has been smoking for years. So their lung tissue or their respiratory tract is not functional anymore. So these patients that have chronic respiratory problems and poor lung function, they tend to retain. So over time, they chronically retain carbon dioxide. So when they breathe out, not all the carbon dioxide is coming out. They retain some carbon dioxide. And that chronic CO2 retention leads to a chronic low O2 level, and they develop a chronic acidic pH over time. Now, because this is a long-term issue, the primary stimulus cannot correct it. So the primary stimulus shuts off and the hypoxic drive is activated, and that patient is stimulated to breathe as a result of low oxygen levels in the blood. So that's the main difference between the primary stimulus to breathe and the hypoxic drive. The primary stimulus to breathe responds to acidity of the pH within the cerebrospinal fluid, and the pH becoming more acidic is as a result of increased CO2 in the body. The hypoxic drive will only respond to low oxygen levels. So that is what is allowing this person to breathe, low O2 levels. So what it means in theory is if this patient is given high flow oxygen, in theory, they can stop breathing if they are relying on their hypoxic drive. So these are patients that you gradually have to reintroduce the patient to high flow oxygen if it is required. We can't just give them high flow oxygen off the bat. We have to gradually reintroduce high flow to these patients. That's the primary stimulus to breathe and the hypoxic drive. Primary stimulus to breathe is stimulated by changes in the pH as a result of increased CO2. Hypoxic drive responds to low oxygen levels. Are there any questions? All right. So that's that. Now, let's follow the movement of air from the environment down to the lungs. So we need to understand that movement and what is actually happening. Now, within the brain and the spinal cord, let's say the spinal cord, you have what's called the phrenic nerve, and you have what is called the intercostal nerves. The phrenic nerve goes to the diaphragm, the intercostal nerves goes to the intercostal muscles. The phrenic nerve originates between C3 and C5, that's cervical vertebrae, that's a cervical vertebrae 3 to 5, that's where the phrenic nerve is going to come from. And below that, the intercostal nerves will branch out. Right? So remember, phrenic nerve goes to the diaphragm, intercostal nerve goes to the intercostal muscles. Now, with that said, let's follow the process. Now, before going to the movement, you need to understand some important concepts. So the first one is volume and pressure works inversely. So volume and pressure works inversely. Does anybody knows what that statement means? So what does that mean exactly? Anybody know? Go ahead, Mr. Graham.
So, in my understanding, an increase in the volume of air would propose a decrease in the volume of pressure, and vice versa.
Okay, that would be correct. So volume and pressure works inversely. So if volume increase, pressure decrease. If pressure increase, volume decrease. We need to understand that concept. The other thing that we need to understand is that air will always move from where there is a high concentration to where there is a low concentration. So there's an individual. The individual is in an environment where there is not enough oxygen available. So there is more CO2 building up in the body. As CO2 starts to accumulate in this individual's body, in the brainstem, the chemoreceptors for the primary stimulus will start to pick up this change. So that CO2 is going to combine with water and it becomes carbonic acid and it causes the pH to become more acidic. The chemoreceptors in the brain will detect this drop in the pH and then it will initiate impulses. So it's going to send an impulse via the phrenic nerve, which goes to the diaphragm, and it will send signals via the intercostal nerve, which goes to the intercostal muscles. So the diaphragm will start to contract and the intercostal muscles will start to contract as well. When that occurs, the volume of the chest increases. So the size of the chest will increase. So the rib cage move up and out. So that's a change in the volume. The volume of the chest increase. When that occurs, the intrathoracic pressure, that is the pressure inside the thoracic cavity, will drop. So there's a negative pressure that is created inside the lungs at that point. And then the air that is outside the body will then move from where there is a high concentration to low concentration to fill the space inside the cavity. So as the lungs start to fill up with air, there are stretch receptors. So there are stretch receptors that will tell the brain that, hey, we have enough air in the lungs. This is enough. Once that occurs, the stimulation of the phrenic nerve and the intercostal nerve stops, and then the intercostal muscles and the diaphragm relax. And when that occurs, the size of the thoracic cavity decreases. So the volume of the thoracic cavity is going to decrease, which causes an increase in pressure inside the thoracic cavity. And that results in air being pushed out of the lungs. Now, with that said, it simply means that when we breathe in with negative pressure, and when we breathe out with positive pressure. So that's the movement of air. Are there any questions? Go ahead, Mr. Graham.
So, to my understanding of what you just said, sir, based off what you just said about breathe in and breathe out with positive and negative pressure. So, is that the muscle contracts um, to push out air outside the lungs and relaxes to when inhaling?
No,
Not the case. All right.
no. So if you look at these two diagrams that I have here, the one on the right represents inhalation, right? So the arrows are moving outward to represent that the thoracic cavity is increasing in size and the pressure is dropping inside of it. So in order for the thoracic cavity to increase in size, the intercostal muscles must contract and the diaphragm must relax. So inhalation is the active part of breathing, right? And that means that contraction of muscles occur during inhalation. Exhalation is the passive process of breathing. So no muscles should be used during exhalation. If you see a patient using muscles when they are exhaling, they are not in good shape. You're not supposed to be using muscles when you're exhaling. That's a bad sign. You got that, Mr. Graham?
Yes, sir. Understood now.
All right. Mr. Jones, do you have a question?
Just for confirmation, you said that when we breathe in with a negative pressure and breathe out with a positive pressure?
That's correct.
All right, thanks.
Good. Any other question? Now, these concepts are very important for you to understand before we go into airway management. So it's very important that you understand what is meant by the primary stimulus to breathe and the secondary or hypoxic drive, and the difference between negative pressure and positive pressure. Because when we breathe for a patient that is not breathing on their own, we are creating negative pressure. So we're actually going against the normal physiology of breathing. That's why it has to be done a particular way. So it's very important that we understand this. Now, let me put my chart away. All right, so putting that away. So my first question, if I had a patient in front of me and I wanted to assess his or her lower airway, what are the things that I would be looking at? to determine that this patient is breathing adequately. So I have a patient in front of me, and I need to assess the lower airway. What are the things that I would be looking at to determine if this patient is breathing adequately? Go ahead, Mr. Roberts.
One other thing would be the chest movements.
Okay. Anything else? Anything else? Anything else outside of chest movement?
That I can recall right now, sir.
Because a patient can be moving their chest and they're not breathing adequately. All right, so let me try someone else. Mr. Doheny, go ahead.
I would check if like if the patient appear like pale or blackish blue to because that would indicate that the patient isn't receiving enough oxygen.
Okay. Anything else outside of that? Go ahead, Mr. Scarlett. Is there anything else outside of that? All right. Let me go back to my whiteboard. All right, so remember now, people, in EMS, everything that we do follows a sequence. Everything follows a sequence. So if I have a patient in front of me and I need to assess the adequacy of that patient's lower airway, things that I need to consider. One, is this patient responsive or unresponsive? That's the first thing. What is the patient's level of consciousness? Right? That's one. Okay, enlarge that. All right. I'm gonna actually stop the